Welcome to the deep dive. Today we're looking at a really pivotal paper from 2007. It's called Shifting Paradigms in the Treatment of Lower Extremity Vascular Disease, a report of 1,000 percutaneous interventions. So if you've ever wondered how doctors approach those blockages in leg arteries, this deep dive is basically your shortcut to understanding a big change in thinking.
Absolutely. It came out at a really interesting time. I mean, surgery, bypass surgery, that was the standard for a long time.
Right.
But solid data backing up these percutaneous interventions, the ones done with catheters, less invasively wasn't as common then, especially not from within the vascular surgery world itself.
Okay.
The paper mentions the basal trial, but this study really aimed to add a much bigger chunk of evidence.
Got it. So let's dig into the study. What exactly were they trying to achieve?
Well, the main objective was pretty straightforward.
Yeah.
Report the outcomes from 1,000 procedures. 1,000 consecutive percutaneous interventions, all done below the groin, by one vascular surgery group between 2001 and 2006.
Wow, 1,000. That's a lot of data points.
It really is. Gives you a solid base.
And who were the patients in the study? Were they all facing, urgent situations?
Not quite. It was a mix. They split them into two main camps. About 46% had claudication.
That's the leg pain when walking.
Exactly. Pain with exertion because of poor blood flow. Then the other group, a bit over half, nearly 53%, had what's called limb-threatening ischemia, much more serious.
Okay, limb threat.
Yeah, and even within that group, they broke it down further. Some had rest pain, so pain even without walking, and the majority, actually, about 72% of that group had tissue loss. Think ulcers, gangrene.
So a real spectrum of disease severity there. What kinds of treatments are we talking about when they say percutaneous intervention?
They used the standard toolkit for endovascular work at the time, so things like balloon angioplasty, just inflating a balloon to open the artery.
Right.
Sometimes angioplasty with stenting, putting in a little scaffold to keep it open. They also used laser angioplasty and atherectomy.
Atherectomy. That's where they remove the plaque.
Precisely. Physically cutting or grinding away the blockage. And they did this in the big arteries in the thigh. The femoral, the one behind the knee, the popliteal, and even the smaller tibial arteries down in the calf.
Okay. And how do they gather all this info?
Good question. They collected the data prospectively. Meaning they planned ahead of time what data they wanted and collected it systematically as they did the procedures. Then later, they looked back at it all. That's the retrospective analysis part to see what the outcomes were.
Okay, so they set it up beforehand, then analyzed it after the fact. That makes sense for trying to avoid bias.
Exactly. It strengthens the findings.
So painting a picture of these patients, what were they like generally, health-wise?
Yeah, this is where you really see the challenge. The average age was up there around 71. Just over half were men.
Okay.
But the comorbidities, the other health issues, wow. Hypertension, high blood pressure was incredibly common, 84%.
84.
Yeah. And over half, 51%, had coronary artery disease. Diabetes was also really prevalent, 58%. Add in smoking, 52%. And chronic kidney problems in almost 40%.
Phew. So these were not simple cases, a really complex group.
Definitely. A very medically complex patient population.
So given that complexity, how did these interventions actually perform? What were the results? Let's talk patency first. You mentioned that term. Can you break down what that means?
Sure. Patency is just about whether the treated artery stays open. Primary patency means it stays open all on its own, no repeat procedures needed on that spot.
Okay.
Secondary patency is a bit broader. It counts arteries that might have narrowed again or reoccluded, but were successfully reopened with another catheter procedure.
Gotcha. Open versus open with a little help later.
Pretty much. So for the claudication patients, the less severe group, the immediate risk was very low. Third-day mortality was only 0.5%.
Very low.
And looking out 2 years, the primary patency was decent, around 62%, and secondary patency was nearly 80%. And crucially, the amputation rate in this group was tiny, 0.5%.
Those numbers seem pretty good, especially considering the patient's other health issues. What about the limb-threatening group, the more severe cases?
Yeah, as you'd expect, it was tougher going there. The 2-year primary patency was lower, about 37%. Secondary patency was around 55%.
Lower, definitely.
But, and this is really key, the limb salvage rate, saving the leg from amputation, was still high, almost 80%.
Okay, so even if the fix didn't always last perfectly on its own, they were still saving limbs most of the time.
Exactly. It shows these techniques could often stave off that worst-case scenario, even in very advanced disease.
That's a critical distinction. Did the study figure out why some people might have problems come back? Any predictors?
They did. They ran a multivariable analysis, a statistical method to isolate factors. And interestingly, just having limb threat as your reason for the procedure in the first place was a big predictor of recurrence.
Makes sense, starting with worse disease.
Right. Other predictors were diabetes, high cholesterol, coronary artery disease, those comorbidities we talked about, and also the complexity of the blockage itself. They used the TASC classification for that.
TASC.
Yeah, Transatlantic Intersociety Consensus. It's a way to grade how bad the blockage is, length, location, calcium, things like that. TASC-D lesions, the most complex ones, were strongly linked to the disease coming back.
Okay, so more complex blockages, more underlying health problems, higher chance of needing another look later. That tracks. What happened if the problem did come back? Were they out of options?
Not necessarily. For patients who did have recurrent disease, a good chunk, just over 60%, actually had another successful percutaneous procedure, a reintervention.
Or they could often fix it again the same way.
Often, yes. About 7.5% actually didn't need anything further done at that point. But for others, it did mean moving on. Around 12% ended up needing bypass surgery.
The more traditional open surgery.
Correct. And unfortunately, about 20%, 1 in 5, eventually required an amputation down the line.
So it underscores that endovascular isn't always the final answer. But that reintervention success rate is interesting. How did those second-round procedures compare to the first ones?
This was one of the really striking findings, actually. The patency rates after a reintervention were statistically the same as the rates after the initial procedure. The p-value was 0.97, meaning no real difference.
Wow, okay, so doing the first procedure didn't seem to burn any bridges for doing another one later, effectiveness-wise.
That's exactly the implication. It suggests that trying the less invasive route first doesn't necessarily compromise your future endovascular options, which is a pretty big deal.
Definitely. So, stepping back, how did the authors frame the importance of their own study? What did they see as the main takeaway?
They felt it really captured and, frankly, helped drive the trend towards using these percutaneous techniques for peripheral artery disease, especially getting surgeons, vascular surgeons, more comfortable with it.
Right, within the surgical community.
Yes. And they pointed to a few reasons why it had an impact. One was just the sheer size, 1,000 procedures is substantial. Another was the quality of the follow-up, looking at real clinical outcomes, like keeping the artery open and saving the limb, not just, whether the specific spot looked okay on an image immediately after.
More clinically relevant outcomes.
Exactly. And importantly, they included both the claudicants and the critical limb ischemia patients. At the time, a lot of the existing literature had smaller numbers, maybe less robust follow-up, or focused narrowly on just retreating the target lesion. This paper offered a broader, more clinically useful picture.
It filled a gap in the evidence base then. And you mentioned the significance of it coming from surgeons.
Absolutely. Publishing this in a major surgical journal done by vascular surgeons, it signaled a real shift. Vascular surgery has its roots in open bypass, especially for complex disease. This showed the specialty embracing and developing expertise in these endovascular methods, even for challenging cases. And the paper details some complex stuff they were doing, treating multiple levels of disease, dealing with tissue loss, working on those tricky small tibial arteries with advanced guide wires and devices. It showed surgeons were tackling the hard stuff endovascularly.
So it wasn't just simple cases.
Not at all.
Were there any other specific findings they really highlighted?
Yeah, a couple are worth mentioning again. The results in the tibial arteries, those small ones below the knee, showed 2-year primary patency rates in the mid-30s% range.
Not super high.
No, and they didn't find a significant difference between just balloon angioplasty or using atherectomy there. The author commentary, even looking back from 2019, noted that finding durable solutions for tibial disease was still a major unmet need. So that remains a challenge.
An ongoing challenge area.
Definitely. And the other big one, as we discussed, was that reinterventions seemed to work about as well as the first ones. That really supported the idea of trying endovascular first without worrying too much that you're ruining future options.
Okay, so pulling it all together, what's the big contribution of this 2007 paper? How did it change things?
Fundamentally, it provided strong evidence from a large, well-documented series that an endovascular first approach was a safe and effective strategy for many patients with lower extremity ischemia. The outcomes were favorable, complications were low, even in complex patients.
Right.
It helps set expectations. What kind of patency can we reasonably expect? How often might reintervention be needed for claudication versus limb threat? It allowed for a deeper dive into which factors really drive outcomes. It wasn't just about can we do this, but how well does it work, for whom, and for how long?
Giving surgeons and patients more data to make decisions.
Precisely. It empowered vascular specialists to confidently offer less invasive options more broadly, potentially improving recovery and reducing surgical morbidity for a lot of people.
Okay, seems like a truly landmark study in this field. So here's something for you, our listener, to chew on. This study is from the mid-2000s. Think about all the tech advancements since then. New types of stents, drug-coated balloons, better imaging. How might those changes have further shifted the paradigm? What new questions might this seminal work have led researchers to ask next? Something to ponder. Thanks for joining us for this deep dive.